Thyroid gland palpation. Palpation methods. The methods are the standard method, the Lahey's method, and the Cryle's method. The Lahey palpation method. Sitting patient, standing doctor in front of the patient. The gland is pushed to one side. It is ideal for palpating the gland margins. Cryle's palpation method is done by the thumb pressure over the swelling to feel small nodules on deglutition. The standard palpation methods. The sitting patient and the doctor is behind the patient. The thumbs of the doctor are at the back of the neck, and the other fingers of both hands palpate the gland from each side. Feeling of the skin temperature at the thyroid gland region by the back of the hand. Gland palpation for tenderness. Lateral flexion of the neck towards the side of examination to relax the muscles and give good palpability. Palpate for the size, the shape, the surface, the consistency, the border, and others. Palpating the tracheal rings for detection of the lower limit of the gland. We feel it if the lower limit is above. We don't feel it in cases with retrosternal extension. Palpation of the deep posteromedial surface of the thyroid gland. The extent of the enlarged gland, whether the whole gland, one lobe, and or isthmus only, or solitary nodule. If the entire gland or one lobe is enlarged, we do palpation for the surface, whether small, nodular, or ocellated. We palpate for consistency, whether soft, firm, hard, or variable. We palpate for retrosternal extension, whether the swelling extended retrosternally or not extended. The consistency. Soft consistency is felt by the finger palpation of a web space between the thumb and index finger with relaxed hand. And firm feeling of the web space with contracted hand muscles. The hard feeling of a web space adjacent bones. The bones are hard. Cystic-like feeling of an inflated balloon. And variable consistency or heterogeneous consistency. Physiological goiters are soft. Colloid goiters are also soft. Nodular goiters are firm, and malignant goiters are hard. Palpation of the lower limit of the thyroid gland to know whether there is retrosternal extension or not. Solitary nodule. To know the solitary nodule, we note the location, whether in the isthmus or in one lobe. It is a simple nodule. Its size, small, large, expressed in centimeters. Its consistency, whether soft, firm, or hard. The And we should palpate the rest of the gland. If the rest of the gland is palpable, this will be nodular goiter. If the rest of the gland is not palpable, it is truly a solitary thyroid nodule. Paradox about consistency of the thyroid nodules. A thyroid cyst feels firm, and a thyroid solid swelling like adenoma feels soft, contradictory. Feeling of a thrill in primary toxic goiter. Mass fixity. The mass is fixed or mobile. Fixed goiter occurs in malignancy or with thyroiditis. For tracheal shift, we do Kochard cyst. For carotid pulsations absence, we do the Beres sign. Bilateral, huge goiters are difficult to feel the trachea. Determining the position of the trachea, if there is tracheal shift or not. Palpation at the left side, search, central search, and right side search by the finger. Tracheal deviation, Kochard's test. We ask the patient to extend his or her neck. We ask the patient to take heavy, deep breaths through the mouth continuously. The examining physician compresses the swelling from the front and bilaterally. The test is positive if a stridor occurs when the lateral lobes are pushed posteromedially with the fingers of the examining doctor. The test is an 11 to 12 minutes procedure. The normal trachea, caliber and shape, and the trachea with tracheomalacia. Discovered trachea and tracheomalacia. Feeling of the carotid pulsations against the sixth cervical transverse process at the groove between the thyroid gland and the sternomastoid muscle. The Beres sign. Absence of the carotid pulsations on one side of the thyroid suggests malignancy. Push gently on each lobe of the thyroid with the thumb. The development of stridor suggests thyroid cancer, thyroiditis, or significant goiter. With tracheomalacia, if there is tracheomalacia, we do the Kochard test to prove or exclude the presence of tracheomalacia. The Beres sign. Feeling of the carotid pulsations firstly at the normal side, then at the diseased side. With benign swellings, the pulsations are well felt or may be displaced posteriorly. With malignant swellings, the carotid pulsations become absent at the diseased site. Skin palpation. The skin cannot be pinched or glided over the swelling. This, is this means that there is infiltration of skin anchored to the swelling. Percussion of the sternum to prove or exclude retrosternal extension. Auscultation may reveal a systolic brew in primary toxic goiter due to hypervascularity. Good luck and best which is